All right, guys, this is part 4. I'm sorry I got a call and it cut it off. So now hopefully we'll just have 4 videos for chapter 36. At least they're fairly short and they're uploading pretty fast. So now we're going to pick back up. We're going to skip pheochromocytoma because that's not something you typically see. And we're going to go on to Addison's disease. All right. So just a little review. So far we've talked about, and I did find a table for your review. All right. So if you guys need to review each gland found in the endocrine system, plus the hormones that it excretes, I did find a table on page 822 for you to look at, and it might make things a little bit easier to understand. So far, what I want to review before we go on with the Addison's disease is the anterior pituitary, now that you've got something laying in front of you. And you see in the anterior lobe of the pituitary on table 35-1, you can see the first part of those, all the ones that anterior lobe, those are all tropic hormones. And what you have to remember about tropic is that hormone is actually excreted just to make another gland in the endocrine system work. Okay? For instance, talking about growth hormone. All right, the growth hormone stimulates a lot of other tissues in the body, and that is going to be something that's when we talked about giantism and acromegaly. All right, TSH, see if to the side it says that it actually stimulates the thyroid. So TSH is thyroid stimulating hormone. That hormone is secreted by the pituitary just to make the thyroid pick itself up and work, so it can make its own steroids, T3 and T4. All right. And then now we're going to be looking at an adrenal problem. Your adrenals sit on both kidneys, and they're going to produce what I kind of want you just to think of as steroids. We've got adrenal corticoids and mineral corticoids. And and when you hear those words, I want you to think of steroid, okay? And if you look right here, so it can go on, I want you to notice the hormone ACTH, adrenocorticotropic hormone. And you see out to the side that its target tissue is the adrenal cortex, all right? So that means we actually have a hormone secreted by the anterior lobe of the pituitary that stimulates the adrenals to work, all right? And that's going to make more sense here in just a minute. So my adrenocortical insufficiency, we call Addison's disease, means that my body is not making enough of these steroids, the mineral corticoids or the glucocorticoids. And that can happen by primary insufficiency, which means that my adrenals are just not working correctly, or it can come by secondary insufficiency, which means that my pituitary is not working correctly. I'm not getting that tropic hormone that stimulates my adrenals to work. So signs and symptoms of a low production of these steroids. It says in early stages of Addison's disease, clinical manifestations may be so vague as to be annoying, but not really get a diagnosis. Hence, it's easily missed or misdiagnosed. Later, as the hormone insufficiency worsens, there are several symptoms associated with fluid and electrolyte imbalances and hypoglycemia. Now, let's stop right there. So the steroids that circulate in our body have a lot to do with regulation of our blood sugar, okay? So, if I don't have enough steroids circulating, then my blood sugar might go low. On the other hand, if I have too much steroids circulating in my body, as in with something we'll talk about in a few minutes, then my blood sugars may go very high. I can do that normally too. I can do that with a medication, I mean. If I'm working on the floor and I have a patient who is diabetic and I give them a steroid like prednisone, okay, a steroid, maybe they've got a lung infection and they need a steroid for their lungs. If I give them a drug like that, then it can shoot their blood sugar way, way up high. So too much steroids in your body can definitely cause an elevation in blood sugar. So that means where I'm not producing enough steroids, then my blood sugar may be low. So I'm looking at fluid and electrolyte balances and definitely hypoglycemia. Considering the functions of mineral corticoids, a major problem is depletion of sodium, which in return causes depletion of extracellular fluid and potassium retention. The patient experiences generalized malaise and muscle weakness, muscle pain, orthostatic hypotension, and vulnerability. So if I have hyponatremia, remember that water likes to be where salt is, okay? So if I have low sodium, then I'm probably going to lose fluid. And the less amount of fluid I have in my body, then the lower my blood pressure is going to go. So the amount of sodium in my body is inversely related to my blood pressure. So if I am hyponatremic, okay, a low sodium, then very good possibility that I'm going to have low blood pressure, at least orthostatic hypotension. When I stand up, I get dizzy, all right? So, and most of the time, too, when I see a low sodium level, I might see a low potassium level and vice versa. But really focus on the sodium and the blood pressure there, too. Insufficiency of the glucocorticoids, the ones that help regulate my blood sugar, hence the prefix gluco, affects the blood glucose levels and causes symptoms of hypoglycemia. And we're going to do the diabetic chapter next, and we'll talk about symptoms of hypoglycemia, okay? But usually I'm very lethargic, shaky, diaphoretic, which is sweaty and clammy, and I usually see those signs with this too. Diagnosis of Addison's disease is made by lab testing. I'm going to draw a blood cortisol level and aldosterone levels. And I'm going to draw an ACTH, which is the hormone that is secreted by the pituitary that causes my adrenals to work. I can do a CAT scan or MRI to see if there's any kind of tumors related to, or on my adrenal glands. And I can do other lab levels like serum electrolytes levels, so I can look to see how high or low my salt is, my sodium in my body, and my potassium. I also want you to know about cortisol, all right? And this is back from A&P. So our body naturally makes this cortisol, correct? All right. All these cortisol levels are naturally made and they're circulating in our body. All right. So sometimes when we take steroids, and this is important to remember, and I'll probably talk about this on in your farm again. But if I give you an outside dosage of steroids, say a dose pack where I'm taking a lot of steroids on Monday, a little bit less on Tuesday, a little bit less on Wednesday, you see how they step down? It's because when I start taking external steroids, my body stops making its own cortisol because I don't want to have too much. I don't want to have the problem we're going to talk about next. And because of that, I have to wean off of steroids so my body starts producing its own cortisol again. But in this situation, I would probably have to give you steroids because you don't have enough in your body circulating. Treatment says replacement therapy is to provide missing hormones, usually brings about rapid recovery, but the patient must continue taking hormones as a lifelong therapy. This would be things like prednisone or cortisone. Again, those are steroids. Remember, my body's not making enough of these things, so I have to give them to you, and you'll have to take them forever, usually. Nursing management. Make sure you're looking at the bullet points on nursing management. That's not something that we probably have a whole lot of time to go through, so if you have questions about nursing management, we'll get to those. But read through the nursing management portion. And we're going to go on now to the next slide. Actually, your next slide is nursing management. Provide intensive care and support during Addisonian crisis. Actually, we probably need to talk about that. That would be on your next page. So it looks like we're going to talk about Addison's crisis next. It says prevent problems related to fatigue, alleviate any GI problems, and provide patient teaching. So just make sure that you read through the patient teaching on that. Adrenal insufficiency or Addisonian crisis. On the next page, on page 854, it says the presence of cortisol in the body allows the blood vessels to function properly in response to epinephrine and other catecholamines by constricting. Conditions that decrease the amount of circulating cortisol interfere with the ability of blood vessels to constrict. Patients with Addison's disease have a decrease of the absence of adrenal cortical secretions, primarily cortisol, because cortisol is released in response to ACTH from the pituitary gland. Abnormalities in ACTH can release also causes a reduction in circulation of cortisol. Physical stress from the flu or other infections from surgery can send a patient into Addison crisis. Another situation that can cause symptoms of acute lack of cortisol results from prescribed treatment. And that's what we were talking about a minute ago. If I give you steroids because you have some sort of infection and my body's going to stop making its own cortisol. All right. So I have to wean those steroids down so my body knows to start making that cortisol again. And I think all we really need to take from Addisonian crisis is that if I have an Addisonian crisis, then I'm probably going to have extra doses of that steroid at that time. If I get sick or I get really stressed out, people who have Addison's disease, of course, we know have to take those steroids for the rest of their life. But if they get sick and their immune system drops, then they're going to have extra sick doses, extra big doses for that time. And also remember about the cutting down. But I think that's all we need for Addison's disease. For treatment on Addison's, it just says to monitor your vital signs. The blood glucose, definitely, because we know it can get very, very low, and the sodium and potassium. All right, and I think we're good about that. Along with, of course, of giving your steroids. And here, because if you're in Addisonian crisis, you'll probably have to have those steroids IV and not orally like normal. But I think we're good there, so we can go on. All right, Cushing's is the opposite. When I have too much circulating cortisol or too much circulating steroids, then I will look a little bit different. It says Cushing's syndrome is rare, and the symptoms typical of Cushing's syndromes are manifestations of excessive levels of hormones from the adrenal cortex, mineralocorticoids and glucocorticoids. Remember, we always think of those as steroids because that's what they are. Excuse me, I'm sorry. All right. This condition can be caused by excessive secretion of ACTH, which comes from your pituitary. So I could be, I should say in here, I could be secreting excessive amounts of that hormone, causing my adrenals to work overtime. Then I could have a secreting tumor of the adrenal cortex. I could actually have a tumor inside my adrenals that's causing me to produce more of those steroids. I can have an ectopic production of ACTH by tumors outside the pituitary, such as lung cancer. Not typical, though. And then I could have an iatrogenic Cushing syndrome, which is caused by, iatrogenic always means that I've caused that because of a medication. And that is the most common cause, it says. Signs and symptoms of Cushing's, these are something you'll always need to remember. Painful, fatty swelling in the intrascapular space. We call that a buffalo hump right between your shoulder blades. Facial area swelling, we'll call that a moon face, and enlarged abdomen with thin extremities. Bruising, even after minor trauma. Impotence, amenorrhea, which is no period. Hypertension, weakness from abnormal protein catabolism with loss of muscle mass. Unusual growth of body hair, which is called Hirschism, can also occur in women with Cushing's syndrome. It's that they might get a beard and a mustache, or maybe hair somewhere else, I don't know. Can occur in women sometimes. And streaked purple markings on the abdomen can occur because of collections of body fat. They might look like a very big, just purple stretch mark. And then we have, it says they also have a familial disposition. All right, signs and symptoms, we talked about that. Diagnosis, we're going to look at a lab findings consistent with high levels of free cortisol. Remember, my body makes that cortisol, but at this time I've got too much. In Addison's, I had too little. Now I've got too much. And let's see here. We're going to do 24-hour urine tests to do that. If the cortisol is elevated, then we're going to do a dexamethasone suppression test. And the patient is given a steroid at night, and the blood and the urine cortisol levels are measured in the morning. Evening serum and salivary cortisol levels and a dexamethasone corticotropin releasing hormone test may help with the diagnosis. Don't worry about that test. Just forget I said it. I do want you to know about the urine test, and I want you to know about the dexamethasone suppression test. All right? And again, that's where we give the steroid at night, and then we measure your blood and urine in the morning to see how much I still have circulating. Treatment for Cushing syndrome can be treated by microsurgery on the pituitary gland if that's the problem. If a Cushing syndrome is arising from the adrenal tumor, if it's actually in the adrenals itself, then they can go in and take the adrenal out. And then if you have, of course, if you have that adrenal taken out, you're going to have replacement therapy, replacement hormones for the rest of your life. Let's see here. They can also use radiation if it's a tumor. And that's about all you see. Of course, if I've got Cushing syndrome because I've taken too many steroids, then I definitely need to stop taking those steroids. Now, that may not be reversed. Just depends on how long you've been taking the steroids. But nursing management. Oh, actually, on the next slide, you have a picture of someone that looks like me. All right, with Cushing syndrome. And actually, that's your last slide. I do want to look at nursing management a little bit. The primary concern for nursing management is helping them cope with the many systemic problems caused by this disease. It says assist the patient with psychosocial concerns. Well, that's about all you need, I suppose. All right. That's it for chapter 36, finally.